Hello, my name is Valeria Caso. I'm a stroke neurologist from Perugia, Italy, and I have the pleasure to share this moment together with the principal investigator from the MonDAFIS study. I think it's a German study, a poorly German study, about a long monitoring of atrial fibrillation. So first of all, here is Matthias Endres, the chair of the Charité Neurology Department. The senior author of this paper. So, can you please introduce some data about the rationale of the study?
Yeah, thank you, Valeria. So we will be presenting the results of the MonDAFIS study, which is about systematic monitoring for atrial fibrillation detection in stroke patients. And it's well known that the longer you look for atrial fibrillation, the more you find. However, it is unclear whether that has any impact on secondary prevention. That is, whether we have higher rates of anticoagulations and in particular, fewer cardiovascular endpoints. So MonDAFIS, as you said, it's a study performed in Germany in German certified stroke units. It's a multi-center prospective randomized trials, and it was testing whether additional systematic ECG monitoring in addition to a standard procedure on a certified stroke unit would give additional benefit. And the endpoints of the study was the number of atrial fibrillation detected at the stroke unit. And then as the primary endpoint, we were looking at the rate of anticoagulation at 12 months. And also we looked at cardiovascular endpoints up to 24 months. And this is a pragmatic trial, so we included all patients with ischemic stroke or TIA that would not have atrial fibrillation at hospital onset. And it was calculated that we needed a sample size of 3,470 patients. And Georg will maybe say a little bit about our findings.
Georg, you are the first author of this study. So please introduce your results, and then we will have a common discussion on what will this change, if your result will change our let's say clinical attitude, or will we continue as before with atrial monitoring.
So Valeria, thank you very much. Yeah, it's a pleasure for me to tell you the results of the study. So as said before, we aimed to recruit almost 3,500 patients, and we did it between December 2014 and September 2017. So the mean age of the stroke patients was 66 years old. About 30% of them had a TIA as index diagnosis. About 40% of them were female, and about 20% had a prior stroke. So AF was newly detected in hospital in 5.8% of the patients in the intervention group and 4% in the patients in the control group. This was statistically significant, and we figured out that especially age was the main driver for atrial fibrillation detection, and there was also a trend towards a higher rate of atrial fibrillation detection in stroke patients versus TIA patients. And as said before, the primary outcome was a proportion of alive patients treated with oral anticoagulation at 12 months. And overall, we had 2,920 patients with available information at 12 months. And at this time, 13.7% in the intervention group and 11.8% in the control group were on anticoagulation. However, this failed statistical significance. That's why MonDAFIS is a neutral trial, and the last observation carried forward analysis as well as a per protocol analysis pointed into the same direction. So at 12 months, 9.7% of all patients in the intervention group and 8.1% of all patients in the control group were diagnosed to have atrial fibrillation, indicating that we have a lot of patients with being on anticoagulation despite no diagnosis of atrial fibrillation. Main drivers was patent foramen ovale or even embolic stroke of undetermined source. And of those patients, about 80% were on anticoagulation if atrial fibrillation was detected. So we get 8.6% of all patients in the intervention group having AF being anticoagulated at 12 months, whereas 7% of all AF patients in the control group. Once again, this was not statistically significant. And another predefined secondary outcome was the composite of recurrent stroke, major bleeding, or a death, myocardial infarction. But this composite outcome did not differ between the patients randomized to the intervention group or the control group, neither at 6 months nor at 12 months or 24 months. And at 24 months, we get a composite rate of 13.5% in the intervention group versus 14.5% in the control group. And going in more detail, there were fewer deaths in the intervention group within 24 months after the index stroke, which was 4.3% versus 6%, which is statistically significant. However, there were no fewer strokes in the intervention group with this regard. So coming to an end, as said before, systematic ECG monitoring increased the AF detection rate in hospital, but it had no effect on the rate of anticoagulation after 12 months, as well as the composite of cardiovascular outcomes within 24 months.
Thank you. This was very clear. So a question that I have to both of you. So do you think it could have been due to the fact that let's say the follow-up period was only 2 years, so you had to extend, or for the patient selection, only stroke patient, only TIA patient, only ischemic heart patients? So do you think this could have influenced your results?
Yeah, thanks, Valeria. So I think to understand the trial, we need to go back to the rationale. It's a pragmatic trial, and we said we wanted to include all patients in the situation of the acute hospital at the stroke unit. And we wanted to include all patients in which the diagnosis of atrial fibrillation makes a difference in terms of treatment. And that is, they would receive anticoagulation. And that's basically all patients, independent of the stroke subtype, which atrial fibrillation is not known. Also, we thought it's well known that if you use extended monitoring up to many weeks, you will find more atrial fibrillation. That is clear. But this certainly is reserved to a very small group of patients, and it's not something you can do in routine. So that's the starting point of MonDAFIS. And what we realized with our systematic monitoring in the end was a recording period of about 5 days. So that was sent to a cardiology lab, it was evaluated and swiftly sent back to the treating physician. And then this led to somewhat higher rates of anticoagulation. But in the end, we found that compared to the standard we have in Germany at certified stroke units, with monitoring, maybe some additional Holter ECG, this does not lead to higher anticoagulation rates and fewer events. So you could also say that the current standard that we have is already pretty good. And it should not lead to the conclusion that we should not carefully monitor our patients. And it should also not lead to the conclusion that high-risk patients should receive maybe even extended monitoring.
This is a very good point. So you say already in the stroke unit you have a high standard of care. You already monitored them. So probably there is no additional value of prolonged intensive monitoring.
Well, I would say unfortunately for the study, but unfortunately for the patients during the last 5 to 10 years within the planning of the study in the last 5 years. I think the awareness of the importance of atrial fibrillation detection has increased. And the average stay at the monitoring place in Germany is 72 hours already. And apparently also the quality of evaluation at the monitoring is fairly good. So in our cohort, relatively young, relatively mild strokes, in routine, we find in 4.1%, we find atrial fibrillation in routine, which is higher than we expected in the planning of it.
Georg, do you want? Yeah.
There is nothing to add. I think Matthias just mentioned it. I think that's a good sign that the message that AF detection is important has reached clinical practice. That's, I think, one of the major findings of the study.
So what would you, as a last comment, what would you tell to the patient who are now, or also general population, who are all buying these apps for the detection of atrial fibrillation, so which will clearly overload our clinics with short measuring out of context and so on? Have you any comment on this?
Well, so we're talking about primary as well as secondary prevention.
Yeah.
And I think that these new tools and apps just provide a chance. As you said, you're totally right. We have to focus our forces. We have to strengthen our efforts to screen the right patients. And in previous studies, think about the Huawei heart study or the Apple heart study, just focusing on primary prevention. I think not the right patients have been screened. But I think that screening stroke patients is definitely worth it, especially if you can empower the patient and the relatives to do it. And if they are suspicious of atrial arrhythmia, then we should have a program in place that they get a standardized follow-up to finally find AF, which often goes undetected because it will have implications for stroke prevention, and that's important.
Thank you. I really thank you very much for this nice interview, and I have only to say compliments for your great work. I think it was really important and pragmatic trial, and will add, surely, as we said, a lot to our daily routine practice. Thank you very much.
Thank you.